Okay, good morning everyone. First, sorry for not being able to do this talk in Spanish. I promise that next time I'll be ready for that. It was a great talk, so I just want to add some comments on the question about lesions less than 1 centimeter, asymptomatic, and when you treat with immunotherapy or target therapy alone. On our center for lesions with less than 1 centimeter and asymptomatic for melanoma, if there is less than 10 lesions, we discussed with double immunotherapy as a upfront treatment. There's phase 2 studies, so we are still debating if this is going to be the standard of care or not. For patients with EGFR positive, T7M0 mutation positive, we also discuss lung cancer, discuss osimertinib as first line. If small lesions, not symptomatic, and patient is not concerned about the risk of bleeding or growing or disseminating. So these are the two kind of situations that we discuss, giving immuno or target as upfront treatment. On the boost for the cavity, we actually, for cavities that are bigger than 40 ml, we usually will do 27 grays in 5 fraction to the full cavity. So it's a big cavity, and you need to do CTV margin, so they end up being like 100 mLs, and then we do 32.5 to the GTV, to the tumor. So we integrate a boost to the tumor. Usually, if it's feasible to go back and do a resection, we'll ask for the surgeons, but if it's not, that's the approach that we do. And on the leptomeningeal, we have a series on focal leptomeningeal disease. We are seeing this more and more nowadays after ALK agents or EGFR agents or after immunotherapy. So focal, up to 5 focal leptomeningeal presentation, we were able to treat with 32 in 5 or 30 in 5 or 27.3 in 5 with a 3 millimeter CTV margin. And we have a local control of like 90%, and neither of the patients develop diffuse leptomeningeal over time. It's about like 60 patients we published at the lung cancer research journal. It's a nice series, and we have pathological proven for all these lesions, proving that they were leptomeningeal disease indeed. Okay, so now moving to recurrent glioma and the role of radiosurgery. Again, thanks for the invitation. These are my disclosures. So before we start, I just want to highlight that in the last couple of years, since 2016, we have been facing a major change on how we diagnose gliomas. So especially with we moving for histopathology to a molecular diagnosis. So in 2016, we noticed a big change on from the 3rd to the 4th edition of the WHO classification, and now in 2021, that is getting even more strong. And why that is important for us today is because with a molecular diagnosis, we have a better diagnosis, we have a better understanding of the disease, and that will open pathways for us integrating treatment with target therapies, with other kinds of therapies on the upfront scenario and actually on the recurrent scenario as well. So when we talk about mutation, I think like all of us as radiation oncologists, we must know and understand how they work and who they are. So the most importants are highlighted in blue, like IDH1, which is usually the first one to be assessed, and then one P92 co-deletion, RTRX, MGMT methylation, and the Stone H3K27M, which tells us classification and how these patients are going to respond to treatment and especially their prognosis. So they help us organize our previous astrocytomas, or oligodendro, primary GBMs, secondary GBMs, based on their molecular features. Here, just for reference, this is a very nice review on Nature that shows how we can diagnose and look into these tumors. So let's go for what matters for us. So after we do a nice diagnosis, so we all need a good diagnosis, so then we go for general management of gliomas, and that includes surgery, systemic therapy, radiation therapy, observation, imaging surveillance, and the recurrence setting. We can also discuss all these treatments, and our focus here will be recurrence. So this is just a start as a general management rule. That is just a table from a study, but everybody is aware that for upfront management from glioblastoma, you start with surgery followed by chemoradiation, and then temozolomide alone for up to 12 months. And you can have different fractionation depending on the patient age. And then on the right here, you can see the the guidelines, the ASTRO guidelines, how to delineate these tumors. And these are important because you need to understand what kind of guidelines you're using at your center, because that will help you to define recurrence and progression, and that will also help you to define how much dose you can give to the area of progression. So it's very important for you to make this standard, so you either can go with like the RTOG, the ERTC, or any other guidelines, but make sure that you know what you are doing. So just quickly going through the high-grade gliomas, as I said, standard treatment is from the STUP trial and PERI trial. So STUP trial for younger patients, surgery followed by chemoradiation, and the STUP trial and the PERI trial for elderly patients, surgery followed by chemoradiation with 15 fractions of radiation. However, despite of our best efforts, survival is still not great, and almost all patients will relapse in the first 2 years. And most of the patients, actually, they relapse inside the radiation field, telling us it's not about dose, but it's actually about biology of these tumors. These tumors are aggressive, and in a lot of the cases, about 60 to 70%, they will relapse within the 2 centimeter margin. But before we jump to treatment, we need to understand that there's something that is called pseudoprogression, and this is getting more and more important nowadays with more access to imaging and early imaging. So this is a transient event that looks like progression, but in the case is not progression. It's actually an increase on the permeability of the tumor vasculature from the irradiation and temozolomide. So then you can see this residual enhancement growing over time, but then after a period of time, usually 3 to 6 months, it starts decreasing. So why this is important? It's important because you need to define very well your recurrence before you offer patients treatment for recurrence. And for that, RANO criteria was developed, and it's usually they say that you cannot define progression before 12 weeks, so you need to wait at least for 12 weeks after chemoradiation, and then you need to see progression in the imaging, and the progression, the enhancement must be majority of them outside the 80% isodose line. So majorly for us to define early progression, it needs to be outside the field of radiation, or if you have a biopsy. So if you do a biopsy and biopsy show there's viable tumor, so there's nothing we can discuss against that. So when we talk about recurrent glioma, there's no standard of care. So we have many options such as repeated surgery, re-radiation, systemic therapy, and best supportive care. Re-radiation is being increasingly used in North America, and especially against surgery, because then you don't need to put that patient to the risk to go to another big surgery and all the complications associated with that. So when we talk about radiation on the re-radiation setting, so most of the studies, so I'm highlighting two systematic review here, are case series. We have a few phase 2 studies, and I'm going to highlight one of them on today's talk. Most of the treatments are from 1 to 10 fractions. The dose on the re-radiation setting from 25 to 50 grays, plus or minus systemic therapy. Most important prognostic factors include histology, age, interval from previous radiation, performance status, reoperation, and PTV volume. As we know, there's low evidence in heterogeneous outcomes, but there's a growing evidence for the use of stereotactic radiation and radiosurgery. And why is that? Because we have been facing a technological advance. So now we have better imaging, we have better ability to plan and deliver the dose, and actually that has improved our therapeutic ratio. So when we talk about recurrence, after recurrence, median survival is about 6 to 12 months when we offer patients radiosurgery or stereotactic fractionated radiotherapy with low rates of toxicity, 5 to 20%. And that's only possible due to technological advance and also patient selection. So, and when we talk about patient selection, it's always key for us to remember that what is most important here is 1, defining recurrence, and 2, accurate delineation of targets and organs at risk. So that's crucial here because we want to increase the ability of controlling the tumor and also decrease the odds of having any issues with side effects, most importantly, radionecrosis. So for that, When we are planning these patients, we usually will be using MRI, especially the T1 enhanced and the T2 flare. These are the choice imaging for us at our center. When we are talking about DTV, it's usually the residual lesion on a contrast enhancing sequence. If the patients they go to surgery, we actually, most of the time, will need to include the full cavity for a second round of radiation. But nowadays, most of these patients, because of their prognosis, they are not going for surgery, at least at our center. So when we talk about the CTV, we usually add some margins from 0 to 5 millimeters, and again, you constrain for the anatomic margins. Usually when we treat with single fraction, with SRS, there's no margin, so it's 0 CTV margins, and then there's another 2 to 3 millimeters when you're giving 3 to 5 fractions. And the PTV expansion, it depends on your center and your setup. It can vary from 0 to 3 millimeters. At our center now is 2 millimeters with the thermoplastic mask. So, and why this is all important is because when we are giving re-radiation, the most limiting factor is the brain tolerance. So how we are going to protect the patient's brain, so we are going to give the patient a good local control with a low risk of symptomatic necrosis. So when we do re-radiation, the series shows that there's a risk of 5 to 10% of radionecrosis development with conventional re-radiation when we have a BD equivalent dose together with both treatments. About 72 grays will give you around 5% risk, and 90 grays about 10% risk. With SRS, with single fraction, we can see the risk increasing when the brain is exposed to 12 grays, when the volume is greater than 6 to 10 mLs. We actually use the 10 mLs as our threshold because we have been seeing that the tolerance is really good. So there's also important other organs at risk, including the brainstem and the optic apparatus. So here again, we need to be calculating the BD dose. There's limiting data on this, but there are some published numbers that you can follow and make sure that you don't damage brainstem or the optic apparatus. So one of the series that help us here is this series that shows to us that the cumulative dose of 80 grays to the chiasm, 79 grays to the optic nerves, and 95 to brainstem is safe on the re-radiation setting. So let's go to radiosurgery now. So radiosurgery on the treatment of recurrent glioma is usually given alone or in combination with systemic therapy. The median dose in a single fraction is 15 to 18 grays, and the median volume around 4 to 10 mLs. So you can see here the key is that you're selecting small volumes to treat with single fraction. The survival after re-radiation can be ranging from 7.5 months to 13 months, and the progression-free survival 4.4 to 6 months. And there's data suggesting that SRS with systemic therapy can increase survival, especially on MGMT methylated patients as expected. So the risk of radionecrosis on these patients treated with radiosurgery can vary from 0 to 24%, especially when we don't respect the thresholds, the risk can be very high. So for these patients, we need to have cumulative dose of less than 120 grays that will be associated with less than 10% risk of radionecrosis and when the tumor is 10 mLs or smaller. So for instance, if we consider a patient that was treated with 60 grays in 30 fractions as the STUP protocol, so if we give a single dose of SRS on the re-radiation setting, we'll have biological cumulative dose of about 72 grays, and that will give us, if it's a small volume, less than 10 mLs, less than 10% risk of development of radionecrosis. So just to support this data, there's a systematic review with more than 3,000 patients showing that brain necrosis rates was about 80% for patients when treated with a single fraction and a median volume of 10 mLs, which tells us this is safe and will produce good control and also good survival to our patients. This is just a table showing to us that there's many case series. In this case series, there are patients treated with LINAC, with gamma knife, single fraction, higher dose, lower dose, and most of them, imaging planning would include the T1 gadolinium. The PTV and CTV margins varies, but usually it's in between 0 to 3, so that's important for us to keep in mind. For you who that cannot give a single fraction, you can also give what we call hypostereotactic radiotherapy or fractionated stereotactic radiotherapy. That's what we do at our center. We prefer to fractionate these patients. So then we give 30 to 45 grays in 2.5 to 4 grays per fractions. In our center, we give 35 grays in 10 fractions, and I'll show you guys why. So the median survival here is about 7.4 months to 12.5 months after re-radiation. And there's a study showing that even if you dose escalate, you are able to promote even better overall survival for these patients. But remember that all this data comes from retrospective case series. There's no prospective phase 3 study showing that this data will reproduce in a larger population. The most important study here is the phase 2 NRG trial that actually treated recurrent GBM with 35 in 10 with bevacizumab. This trial showed similar survival about 10 months after the fractionated radiation therapy, and they showed a risk of radionecrosis less than 10% if the cumulative dose was less than 120 grays, which is reasonable and easily achievable after a 60 grays in 30 fraction treatment. So we again here, it's all about dose and volume. For these patients, we try to respect the cumulative dose of 120 grays, which is easy to achieve. So the next steps is making sure that your volume is less than 40 mLs, because if it's more than 40 mLs, then you have a higher risk of radionecrosis, and then for that cases, we actually will go for conventional fractionation. So here is this table again, 2 tables, just highlighting there's a lot of studies, gamma knife, LINAC base, most of them again, T1 gadolinium as the guidance, and margins again varying from 1 to 3 millimeters. So for larger cavities or for larger recurrence, we have also potential to give conventionally fractionated, so giving 2 grays per fraction on 18 fractions, so delivering 36 grays. Median survival time can range from 6.7 to 11.5 months, progression 2.5 to 5 months. Still, we need to define if there's a need to combine with chemotherapy. There's no strong evidence. What we know is that we have low risk of necrosis, so less than 7%, and the risk is still low even for higher or bigger cavities, so cavities up to 100 mLs. So then it's key to define the size, so less than 10 mLs radiosurgery, 10 to 40 fractionated radiosurgery, and then more than 40 and even higher than 100 mLs, the conventional 2 gray per fraction will give you good results. Again, the same kind of table. So I'm getting close to the end. So as I said, we need to define who are the best players here and how we and for who we are going to offer re-radiation with radiosurgery. So the most important prognostic factors are age at re-radiation, performance status, tumor grades. Other factors include tumor volume, as I highlighted today, surgery before radiation, time from the first radiation, use of systemic therapy, MGMT methylation. For us, the most important prognostic factor is also a 6 months interval between the first and the second irradiation, because that tells us more than one thing. That tells us how aggressive the tumor is, so the biology, so showing to us that this tumor is not going to respond very well. Doesn't matter how strong you want to hit this tumor. And in addition to that, it shows to us that we might put this patient at risk of more toxicity without giving him any benefit or her any benefit. Some studies have shown that surgery can improve outcomes, but it's not well established, so it's not a standard of care at this point. So for the clinical use, we use this new COMBS score. So COMBS is COMBS SE is a radiation oncologist from Germany. So she developed this score. This was just updated on 2018. So it gives you values for histology, age, time from previous radiation, resection, and volume. And then you can group them, and then you can actually give like a potential survival in the clinic, so what you're looking at to your patient. So our take-home message here is that radiation in a re-radiation setting is effective and is a safe treatment for recurrent glioblastoma. Appropriate patient selection for both SRS or fractionated radiotherapy is the key for the success. And then when we're looking for the best players, there will be young patients with good performances, especially after a long period from the prior radiation and with a low volume of disease. So these are the players that we would like to offer re-radiation on our clinical setting. And that's it. Thank you.